Thank you, Committee Chair Cantwell, Ranking Member Cruz, and members of the committee. I appreciate the opportunity to testify on my experience with PBMs. My name is Dr. Deborah Patt, and I serve as a breast cancer specialist in Austin, Texas. I serve in the leadership of Texas Oncology, a large independent community oncology practice, and I'm the Vice President of the Community Oncology Alliance. PBM transparency and accountability is critical because patients being able to get their oral cancer drugs in a timely, effective, and sustainable way allows them to realize the benefits of modern cancer therapy. PBMs steering the filling of these pills to their specialty and mail-order vertically integrated pharmacies all too often results in unnecessary delays, denials, and waste for cancer patients getting potentially life-saving treatments. This is a remarkable time when instead of cancer treatment disrupting how patients live and work, or even being a death sentence, they can enjoy their life with their cancer and control it as a chronic disease, much like hypertension or diabetes. Many Americans with cancer can continue to live in their own lives, work at their jobs, teach at their schools, pick up their kids from soccer practice, and eat dinner at their dinner tables. Oral cancer therapy accounts for about 30% of these therapies today, and we anticipate this will grow to over 60% in the next few years. So this is a large issue and it's growing. The increasing use of these effective but expensive specialty drugs and their profit potential has attracted the top PBMs, with the largest three controlling 80% of the prescription drug market, and adding the next three largest adds to 96% of control. This gives these PBMs who are owned by or own the largest health insurers substantial leverage in controlling what treatment patients get and how and when they get it. PBMs frequently delay and detour appropriate and timely therapy for my patients. The delays and detours are difficult to anticipate and limit a doctor's ability to effectively control the cancer. And delays can lead to poor disease control, morbidity, and mortality for the patients we serve. Doctors frequently modify treatment doses to optimize therapy and control toxicities, sometimes in as little as 1 to 2 weeks after starting a treatment. When a PBM mail-order pharmacy is only willing to fill a 90-day script, supplies of cancer medications, then this can lead to extremely expensive waste, as patients may get 1 to 2 additional months of drugs that they can't ultimately use. I urge you to read my testimony about my patient Tanya, a 40-year-old woman with metastatic breast cancer that now is in her brain. Unfortunately, Tanya was blocked by PBMs and the insurer from getting the medication abemaciclib that I believe is one of the most effective therapies in treating her cancer and her brain metastases. As I saw her cancer metastasize and literally grow on the side of her trunk, I couldn't wait for the PBM and insurer to approve my appeal and had to resort to less effective and more toxic chemotherapy. Since December, Tanya has stopped working. When I saw her last week, we had to deal with 2 new brain metastases we observed on her scans and initiate radiation therapy to address these. I don't know for certain that Tanya would be better off if she had the pills I had prescribed. However, I do know that from the peer-reviewed literature that she would have doubled her chances of living without cancer progression at this time in comparison to the chemotherapy that I had to give her, and that she would have had less toxicity, which would have allowed her to continue to work and live a more normal life, again, which is the dream of modern cancer therapy. Due to the power of the top PBMs, the majority of oral cancer drugs are not filled at our medically integrated pharmacy, but are steered by the PBM to their corporate affiliated specialty mail-order pharmacy. PBMs will tell you that this is a cost-saving measure, but we don't see evidence that cost savings translates into patient or employer savings. In reality, PBMs control the practice of medicine. In addition, PBMs charge our medically integrated dispensing pharmacies steep DIR fees that are unanticipated expenses that are at a high percentage of total cost and increasing substantially. These are couched as quality measures, but DIR fees are not benchmarks on quality measures that are meaningful to my cancer patients. Things like the STAR rating is often benchmarked on hypertension and cholesterol medication filling. As a breast cancer specialist, you really don't want me controlling your hypertension or cholesterol. So this is problematic and not meaningful to cancer patients. We urgently need PBM transparency and accountability, and this legislation takes necessary steps to get us there. Thank you for your leadership in shining the light of transparency on PBMs. While PBMs operate in the dark, Americans battling cancer and other serious diseases suffer. Thank you for this time, and I'm happy to answer any questions.